And this is a typical hallux valgus deformity of the big toe, which can develop at a point of time in the clinical course. And this gives you a typical radiograph where there is a narrowing because of the cartilage loss with the appearance of the osteophyte. And in comparison, you can see how a normal joint looks like, how an osteoarthritic joint looks like. And finally, you can do the joint replacement as a management of that unbearable osteoarthritis. Now the orthopedics has grown so well that at 80, you can make the fellow once more become young and start dancing on the ballroom by doing a good prosthetic replacement for the osteoarthritis. You need to basically encourage, and you are going to do as eminent orthopedicians tomorrow. So please remember, this is the femur, this is the tibia, it has got a prosthetic component. This is how the replacement is considered to be one of the treatment depending on the age of the patient. That's another favorite question of the examiner. If there is any hip fracture, which patients do you want to do open reduction, internal fixation, to whom do you want to do a prosthetic replacement? So please don't forget those protocols. Let's go to the next question. Cystic tuberculosis of the bone. How do you want to treat it, doctor? Curettage and ATT is the major part. Now this question is a challenge, doctor, take it up. Old lady has got a forearm injury, fracture of the distal end of the radius, and she is treated with the bandage. After removing the bandage, unable to extend the thumb because of what, doctor? Rupture of the extensor pollicis tendon, which is a very important complication. Now, what are the borders of the anatomical snuff box is one of the favorite questions of the examiner. Please remember, the ulnar border of the anatomical snuff box is formed by this extensor pollicis longus tendon is what need to be remembered. Now I like to ask you a question. Is the rupture of the EPL tendon in the colles, is it more commonly seen in the minimally displaced colles or maximally displaced colles? It is much more common, frequent in the minimally displaced than the maximally displaced colles fracture is what need to be remembered. So the cause for the tendon rupture is not that broken fragment going and pressing against the tendon and causing the injury. Another favorite question of the examiner. It is the ischemic injury to the tendon, not the traumatic injury because of that broken fragment is what need to be basically remembered. So undisplaced fractures, it is much more common than that of the displaced fractures is what need to be basically remembered. It is of ischemic in etiology. What is the common time where it become involved, doctor? 3 weeks to 3 months. After the plaster cast is removed, typically they will be developing the EPL injury identified by inability to extend the thumb is a very classical clinical history, something which you should not forget. Workman's ischemic contracture in the children, commonly seen with the supracondylar fracture is what you need to remember. Can you tell me what are the two important tendons which are involved, doctor? Flexor superficialis, digitorum superficialis and flexor digitorum profundus are the ones which are typically involved. Even two important nerves, median and ulnar nerve also can become involved in the typically Workman's ischemic contracture is what need to be remembered. Let's go to the next question. Paronychia is basically what, doctor? Is it nail fold or subungual? Nail fold infection is what need to be remembered. So paronychia should not be. What is the common organism? Staph or step? Staphylococci is what need to be remembered. And osteosarcoma, how do you want to treat? A stock question. You need to do both. Above knee amputation plus chemotherapy, both the things need to be combined. You will be using high dose methotrexate with a leucovorin rescue along with the cisplatin, adriamycin, ifosfamide. This combination in addition to the above knee amputation is considered to be the treatment of choice is something you are not going to forget. What is the most common cause for the spinal disease in India? Very peculiar question. Is it spinal cord disease or spinal, there is a vertebral spine's injury? At least we should understand by the simple English TOEFL knowledge that spinal disease means the vertebrae involvement. If that is so, then spondylosis undoubtedly is the cause. But if spinal cord, if you consider in India, it is the trauma which is the most common cause. Accident is the most common cause. Approximately 15 lakh people live with the spinal cord injury in India because of the trauma associated spinal cord injury is what need to be remembered. Otherwise, having that great belt and cervical spondylosis with the development of a shooting pains, that is much more common. But if you consider infections, then tuberculosis is the common cause. Okay. Now, what is Trendelenburg sign, Trendelenburg test, Trendelenburg position? Everything about Trendelenburg examiner wants you to know. So, Trendelenburg sign is basically that gait adopted by someone with an absent hip abductor mechanism because the gluteus medius and minimus injury, or if there is any fracture involving the fulcrum, you find this Trendelenburg sign positive. Trendelenburg test is done in the second clinical posting. That is when varicose veins case is presented to you and you are presenting the varicose vein case. Orthopedics comes in final year, right? So final year clinical wards you will be doing Trendelenburg sign. Okay. Now what is Trendelenburg position? So as a house surgeon while treating the shock patient, place him such that his cerebral perfusion is well maintained is Trendelenburg position. What is anterior draw test, doctor? Typically it is seen in the case of the anterior cruciate functioning, you will be basically testing by checking this anterior draw test. Let's go to the next question. Compartment syndrome typically is associated with a vascular injury, seen in crush injuries, and whenever there is a fracture of both the bones of the forearm is what need to be remembered. So you can see, doctor, that there is blood vessels and nerves which are typically located dividing these three important compartments, that is the anterior and the medial muscle compartment with the posterior muscle compartment, and you are having these two important bones, tibia and fibula. So any crush here can lead to the increase in the pressure within the compartment, which is called compartmental syndrome. Sometimes whenever you have closed after doing internal fixation and you have sutured, then there can be a development of pulselessness with the compartment syndrome. There you need to reopen. So this is post intramedullary nailing. The patient has developed the compartment syndrome with the development of the infarction is what can be classically appreciated. Let's go to the next question. For the duodenal ulcer perforation, what is the most common treatment, doctor? Here you have to be careful. Is he asking about elective duodenal ulcer management or perforation management? For perforation management, no doubt there is a Graham's patch repair is what need to be fundamentally remembered. So when do you do endoscopic intervention in the duodenal ulcer? Whenever there are refractory ulcers, or if there is any bleeding ulcer which is not responding to the medical management, approach it endoscopically is the rule which you should not basically forget. And what is the indication for urgent surgery, doctor? Endoscopically you are not able to achieve the homeostasis that time. And similarly, if there is any recurrent bleeding or if there is any perforation, you will be doing. So can you tell me this classical radiograph, what does it suggest you, doctor? Lateral radiograph showing the diaphragm and there is the air under the diaphragm, free air, which is indicative of the perforated duodenal ulcer. So nowadays laparoscopically also you can identify where is that ulcer. You can place one omental patch. So Graham's omental repair of a emergency procedure for the duodenal ulceral perforation can also be done laparoscopically is what need to be basically remembered. Let's go to the next question. What is the most common retroperitoneal tumor, doctor? Liposarcoma. You can see how this huge liposarcoma retroperitoneally is located. And this is neuroblastoma which also can originate retroperitoneally, but that is not most common. So this is the one which is originating from the suprarenal area is what need to be remembered. So liposarcoma, 95% of it contains that fatty retroperitoneal tumors, 90% are liposarcomas, common between 40th to 60th year of age. They are mesenchymal in origin is what need to be remembered. Now thyroid storm, you need to know everything about it. What precipitate sits and how do you manage? What is your prescription in the intensive care unit for the thyroid storm? I will make you the masters. Infection, surgery, trauma, radioactive iodine treatment, whether it is for any reason, pregnancy and the thyroxine injection excessively or diabetic ketoacidosis or using any atropine like anticholinergic agents or adrenergic agents can precipitate the so-called thyrotoxic storm is what need to be remembered. So here iodine therapy and surgery whether for thyroiditis, thyrotoxicosis is all correct. So what is the management of the thyroid storm? You should not forget antithyroid agents, iodides, especially Lugol's iodine need to be given, and glucocorticoids, dexamethasone need to be pumped, and beta blockers, so the propranolol and esmolol can be used basically to reduce the symptoms of the thyroid storm, and maintenance of a good hydration, management of the acidosis and dyslipidemia. If you know those three things in addition to this prescription, your thyroid storm patient will never pop out. This is a golden rule which you should not forget. In blunt injury of abdomen, what is the most common part of the pancreas, doctor? There is a head of the pancreas, there is a tail of the pancreas. Between these two, you can see there is a neck of the pancreas, which is the most common site for the injury in the case of the blunt trauma to the abdomen, is what I want to underscore to all of you. How do you like to treat annular pancreas, doctor? So annular pancreas will be surrounding which part of the GIT? Duodenum. Hence, you can see this is the pancreas. In the middle of it, you can see the presence of the duodenum, which is sequestered within it. So that is the reason that part of duodenum, forget it, leave it for the pancreas. Duodenostomy. That is before that and after that you cut it and then connect it. So that's the reason, doctor. Duodenostomy, bypassing the proximal and the distal part and then connecting the two, is considered the management in annular pancreatitis. How to differentiate ulcerative colitis from the Crohn's is a favorite question of the examiner. Typically remember, perianal disease is one important feature that tries to differentiate. Rectum can become involved in both, and extraintestinal manifestations can occur in both of them, and also malignancy is prone in both of them. Only they differ in how much they do it. So this gives in a colonic wall, it is showing the acute inflammatory infiltrate which is involving the mucosa and submucosa. There are no fissures, no granulomas. Now can you tell me, is it ulcerative colitis or Crohn's? Very good. So it is typically ulcerative colitis is what need to be remembered. Now what are all the extraintestinal manifestations of the ulcerative colitis, doctor? You don't find succinate balanitis. Where do you find that? Reiter's syndrome is a place where you can come across succinate balanitis, but not here. So synovitis, ankylosing spondylitis, sacroiliitis, erythema nodosum, pyoderma gangrenosum, actus stomatitis, episcleritis, iritis, primary sclerosing cholangitis, and renal stones, and rarely thromboembolic events can be the extra intestinal manifestations of the ulcerative colitis, is what need to be remembered. Now do you find any skip lesions in the case of the ulcerative colitis, doctor? Typically there will be uniform inflammatory reaction. Crohn's skips until it reaches the mouth is the rule, where ulcerative colitis doesn't skip here, it remains within the colon, hence it is called ulcerative colitis. Now cysts in the AD-PKD can be found in the liver, lung and pancreas, but not in the spleen. So typical cystic disease of the kidney should not be forgotten. Thyroid cancer, which is common in the autoimmune thyroiditis. Can you tell me what is that type, doctor? Papillary thyroid cancer. So you can see that finally entrance is all standard questions. Thyroid carcinoma, one question, like you go to the Chetney's restaurant and he will give you some sambar, some rice, some chutney and all that. So also is the entrance. It is not something very peculiar, unexpected. Crocodile is not served to you, or tortoise. Curry is not served to you. So papillary carcinoma, iodine-rich areas. Similarly, those who receive the neck irradiation, they are the two important risk factors for the papillary carcinoma. It spreads to the regional lymph nodes is what need to be remembered. What is the sign par excellence histologically, doctor? Psammoma bodies, orphan Annie cells, these are the classical features. And it is often multifocal in nature. What you are seeing here is a psammoma body in the case of a papillary carcinoma of the thyroid is what I want to underscore. Now let us talk about the cancer of the gallbladder. What is the most common type, doctor? It is typically adenocarcinoma. A long gallstones in the gallbladder can predispose to the adenocarcinoma.